Hello, good evening, everyone. Welcome to another Facebook Live. I am going to wait for some of the audience members to come and join me. It is a little bit past 7, so I apologize for the delay. I'm going to go ahead and get started in a few minutes. I just want to go ahead and see some comments to state that everyone can see me and can hear me well. Till I get a couple of feedbacks, please let me know that you can hear me. So please, if you could alert the members on my private breast implant illness support group face so that they can come and join me on my public page so that the audience can hear me, not only my private group but also the many others who would want to listen. So this is basically a information question answer session. I've requested the patients to go ahead and submit some questions, and I'm going to go ahead and answer to the best of my ability. If I do not know, I'll be the first person to say I do not know, and there needs to be more evidence. Just real briefly about myself, I'm a board certified plastic surgeon by the ASPS, the American Society of Plastic Surgeons, and then also board certified in general surgery. I am also certified in trauma and burns. I don't practice trauma or burns, but now a good part of my practice is essentially focused on breast implant illness. I welcome all my new members to my page. Hopefully you find my private breast implant illness support group page to be informative. We have a gathering of unique group of ladies who are unfortunately hurting and suffering and looking for answers. You know, here we have a lot of data, evidence, the patients, which I will say by far are the most important resource for prospective patients so that you can learn from them to see what is anticipated of their journey to explant, what questions to ask. And I will tell you, as a board certified plastic surgeon, as to how I do it. And I assure the ladies and also the significant others to basically be fully involved so that you can comprehend what is a real entity and a real phenomenon and something that continues to hurt the many. If one patient were to go to 10 different board certified plastic surgeons, you probably get 10 different answers. And if there is a list that's floating around, sometimes that is influenced by financial donations. Unfortunately, the plastic surgeons get promoted, unfortunately, without having been tested and tried. Just like myself, I tell all my patients to basically check and balance in regards to how the surgery is performed, what the reputation of the surgeon is. And what I'm going to try to do here is hopefully share my experience and my expertise as to how I feel that it needs to be done so that everyone gets the best of it. Now, I'm going to go ahead and get basically started with a few criteria that I find are integral. What are the ways one can find out or one can look at from my experience as to what are the different criteria that ensures that the explant was done right? And these are the 5 criteria as you've heard me say, and I'll repeat them. Number 1, the size of the incision. If you have an implant that's 650 cc's and the incision is 3 centimeters, it is impossible for a plastic surgeon to remove the implant from that small incision. So the diameter of the implant essentially dictates the length of the incision. And sometimes I've had to make a larger incision on one side so that I can remove the entirety of the capsule. One cannot say, well, I removed as much as the capsule, as much as I could see. You know, the surgeon needs to just make the incision larger so they can visualize and completely definitively remove the entirety of the capsule, because if that is not done, the whole surgery is not done in the right manner, and then the substance of the surgery was not carried out, which is the entirety of the implant and capsule must be removed along with any inflamed tissue as one system. So the diameter of the implant is key, the diameter into dictating the length of the incision, and that should be a generous amount, usually in the 7, 8, 9, 10 centimeters, depending on the size of the implant. Number 2, the length of time. In vast majority of the cases, if the surgery is done in an hour and a half or 2, that is an impossible time period for someone to go ahead and, i.e. a board-certified plastic surgeon, to remove the entirety of the implant and capsule. I will tell you yesterday when I finished my my second case, it was almost 5:30 p.m. and I didn't start my third case till late, and that's usually been the trend, unfortunately, because the first two cases took such a long time. And the point here is the entirety of the implant and capsule must be removed, and no matter what length of time. And on average, I take 4 hours, 5 hours approximately to doing it safe, doing it right, such that the patient has no need for drains. The surgery is done in a very meticulous way, and it is in the right avascular plane. So the length of time I find is key. If a surgery is done in 2 hours, I will tell you I would love to do the case and be done by 3 o'clock every day, and or do 4 or 5, 6 cases per day. And I will tell you that virtually is impossible in my hands, and I will tell you in the many hands. And I hear from time to time the lift and the end block was done in 3 hours, and I'll tell you that is impossible, and it is a goal that I will tell you in my wildest dream cannot be achievable, as far as being able to complete a surgery in that short a period of time. For example, a lift and an end block. And I'll explain this to you. If you look at, vast majority of the implants are below the muscle, which basically means if you look at the anatomy of the chest, you have the nipple areola, breast tissue, and then you have the muscle, and then you have the implant, and then you have the ribs. The dissection that I carry out, and as you will see, majority of the ladies, their implants are below the muscle. I make an incision at the inframammary crease at the lower part of the breast, and then I essentially identify what is the capsule. Once I've identified the capsule, I essentially ride, i.e. the capsule, in that avascular plane. What do I do to the muscle? Nothing. Because anytime I touch the muscle, I have to repair it. I have a risk of bleeding. I have risks of basically asymmetry, contracture that may potentially occur afterwards, where the skin may attach, and other problems that may result as a result of cutting into the muscle. And there is no need to cut into the muscle if the dissection is done. And as you have seen in the YouTube videos and the initial Facebook posts, that the dissection can be done very nicely, tedious dissection in that avascular field without any significant blood loss. The vast majority of my cases are 5-7 cc's, if at all, on each side, a total of 10 cc's. So if you can imagine now, hypothetically speaking, another patient that comes and she just wants a mastopexy, a lift. That surgery is all above the muscle, right? So this is where you're going to make that incision around the nipple areola, and then you're going to draw out what are the markings that will allow for that excess tissue to be removed such that it's folded inward, which is the lollipop incision, and then the anchor incision. That surgery in itself, just to do a mastopexy on a good pair of hands, i.e. a good plastic surgeon, will take approximately 2.5–3.5 hours. And I find it amusing how an end block and a lift can be done in 3 hours, when just a lift alone in someone who does not have implants, that in itself will take that much time just to suture together. Now, there are people that, mention there's concentric lift or J lift and other lifts. They certainly do not withstand the test of time. And a true lift, a mastopexy, is where you have to rearrange the tissue such that in the dome you have the lifting up of the nipple, as you have seen in the diagrams and pictures, and I'll put one up, and the tissue is folded inward and lifted up such that the nipple areola position is approximately 21 centimeters from the sternal notch to where the nipple areola should sit. So again, timing is very important. Another patient went and had, oh, my insurance is going to pay for it. How long did your plastic surgeon book you for? And you will hear the patients repeatedly say 1.5 hours, 2 hours, and I will say that is virtually impossible. Sometimes 1.5 hours just to rupture the implants, remove them, and that's an absolute big no. So going back to what I would say are the criteria for a successful or a reassurance and confident end block. Number 1, the length of the incision needs to be approximately the diameter of the implant. Number 2, the length of time approximately 4 hours or more. Number 3, you're looking at the implants that need to be returned to the patient, so you know that the implant is intact, it was not ruptured, it was not damaged, and you want to confirm that the implant was basically the same implant that was basically put in, so you want to match the lot number. Number 4, you want to see pictures of not only the implant plus the capsule on the table, but more importantly, the picture of the chest wall showing that the entirety of the capsule being removed. And that is the ultimate of all the pictures, to show that the chest is void minus the capsule, and that there was a sincere attempt, and there was a proof, a photographic evidence of the entirety of the capsule being removed. 5, last but not least, you're looking at that the surgeon's reputation. You know, we all, doctors, lawyers, drivers, you know, whoever it may be, we all have a reputation online now. And we all know, believe it or not, the patients are smart. They do their good questioning, and they themselves know where to go and how to ask the right questions. The reputation of the surgeon that becomes key. So the first and foremost, I remember a patient that came to me from South Dakota, and she asked me, 3 minutes into the conversation I had over the phone, she decided that she was going to come and she was going to explant with me. And I asked her, well, that's too early. You're going to probably end up changing your mind. Mom of 5 kids, very determined young lady in her mid-30s. And she said, well, 2 things. Number 1, the fact you as a board-certified plastic surgeon by ASPS do not put implants, that in itself speaks volumes. And that the fact that you talk about what you do and how you do, and you have videos and pictures of what you're doing, kind of affirms to me that you're the go-to person. Because I will tell you, whoever is putting in implants, breast implants, certainly does not believe in breast implant illness. Because how can you knowingly, willfully hurt someone? And I use the word hurt because ultimately the implants only harm the body. And this is a conclusively proven fact. Because if you look at the FDA warning that just came out last year in October, implants are not meant to be in the body forever. They have been banned before. They're associated with these, what is called the breast implant illness associated symptoms, which is from head to toe. And I'm going to name this, and we have heard this repeatedly, but for the new members, the hair falling off, the skin rashes, the vision problems, the hearing, the vertigo, the clearing of the throat, the change in smell, the taste, the poor dentation, i.e. the cavities that form because of the dryness that causes the dryness of the eyes, that we know from Sjogren's syndrome that is very common in patients with breast implant illness. And we know this for a proven fact because of the MD Anderson study, which was a study of studies published where 100,000 ladies with implants, 80,000 with silicone, 20,000 with saline implants. There was a very significantly high number of patients who had Sjogren's, neck, back pain, lung, chest pain, breathing issues. You have vasculitis, irregularities of the heart, palpitations. You have high blood pressure. You have digestion problems. You have endocrine problems, autoimmune problems. The hallmark of what is breast implant illness, which is dermatological issues. You have plantar fasciitis, you have joint pain, you have patients with urinary tract infections, cystitis, and name me, every single part of the body is affected. The fact that breast cancer, which is the #1 breast cancer and the #1 incidental cancer incidence of breast cancer, being #1 out of 8 women getting breast cancer, obscuring because of a physical exam that's going to obscure the physical exam, or a mammogram that might obscure basically a mass. So all of these are what you will see reasons why implants are bad. Just the fact that they're below the pectoralis muscle and one cannot function effectively using the upper extremity, that destabilizing the shoulder. So you have now patients who are hurting with frozen stiff shoulders, or and again, this is where the whole anatomy of the chest gets altered, because you have the pectoralis muscle that inserts into the humerus, and you see the ladies cannot use their upper arms effectively, young ladies, because every time they do, they essentially compress the implant against. So these are the 5 criteria. The reputation of the surgeon, if you will, is the most important, plus each one of those other factors when combined together. And I want you ladies, I can only do so many of these a year. I have so many phone calls, consults to do, and I say this to you, read up, talk. I have a patient that came to me, she's talked to 15, she said it herself, 15 plastic surgeons. Talk to the surgeons, ask them questions directly. Don't talk to a nurse. I will tell you, a nurse cannot operate. And I hate to say this with all due respect, the nursing staff is amazing in my group, and before and after. They're the ones who know the patient the best on the hospital. But when you want to talk to the surgeon, him or herself. You don't want to talk to a liaison who has no concept of medicine. You don't want to talk to someone who is basically living off on hunches or memorized it like a parrot, that this is how he does it. You don't want to talk to the front desk person. If you talk to my front desk, Jennifer, she's an amazing, nice lady, as you will. She is told by me, and she's basically, she knows better that she cannot give any medical knowledge because, you know, it requires so much. And even after some time, what's in my head, because as you will know, if you ladies were to walk into 100 different plastic surgeons, board certified, and the institution that you want or the private practice that you want, you will be told inevitably the answer, we'll go ahead and take this set of implants that you have out and only to replace with a new set, because that's your best bet, well over 90%. And then this is essentially, if plan A fails, then plan B should not be the same as plan A. Now, I get this question asked a lot. Does breast implant illness happen in everyone? And I say absolutely 100% yes. Now, that's a pretty bold statement that I just made. And I'm going to say, for the fact alone, number one, the implants are not meant to be in the body forever. That's FDA recognized. If you look at any literature in the journals of plastic surgery, implants, once they are in the body, even the newer generation, what they call the gummy bear, even the saline implants, all of these are replete with problems. We know the textured implants are associated with the breast implant associated anaplastic large cell lymphoma. We know they're associated with contracture. So one of the questions I got asked earlier, what is a capsular contracture? This is basically a capsule that forms around any foreign body, be it a hip, implant, or a knee, or any port, for example, a chemo port. In this case, it's not titanium or stainless steel like it would be, for example, a defibrillator, but for example, like silicone. The body in itself forms a capsule around this foreign body. Now, sometimes we do not truly understand why the capsular contracture occur, and it's been shown to occur anywhere in the studies from 3% to as much as 12%. And this is a significant number where there are 4 different grades of capsular contracture classified by Dr. Baker, or the Baker's classification, where class 1 is where you have a normal appearing breast tissue. Class 2 is you have some firmness, but overall it has a soft feel to it, some firmness. Grade 3 contracture is where you have a distortion of the chest wall but no pain. So if you look at the chest, you have asymmetry. One is riding up or laterally displaced, and it is relatively hard to touch, but there is no pain. And grade 4, which by far is the worst and the most involved, is where you have a distortion of the chest wall and you have what is pain. Now, as you will see, the last Facebook live that I did directly from the operating room, this lady with a set of implants from 1980, the one set that she had, it was rock hard solid, like cemented crystals that had formed around the implants that were essentially deflated because the silicone had leaked out, it was ruptured. And we know for a fact, the longer the implants stay in the body, the higher the chance of rupture. Now, if you go back and look at the recommendations made by the FDA, and I want each one to mark my words, you know how they do after a presidential debate or another debate, that they do a fact check. So I want someone to do a fact check, and this is, again, I'm the first person to say if I don't know, I'm going to volunteer and say I do not know, more research needs to be done. But the longer the implants stay in the body, the higher chance of rupture. Those statements by plastic surgeons, oh, if you're 22 and you get your set of implants and you're going to be living with them for the rest of your life till your 80s, that is absolutely a false statement. As the implants stay in the body for a period of time, the chance of rupture increases after a period of time exponentially. So most of the implants from the 80s and 90s are almost ruptured. Till proven otherwise, the study of choice is an MRI without contrast that will look at any potential leak of silicone. Now, I'm trying to give as much information as possible. What is now going back to the question, do all patients who have implants have breast implant illness? And the answer is yes, because the implants are not meant to be in the body forever. They cause and they're replete with problems. There are patients who sometimes don't know better. Sometimes they think it's the menopause in their 50s, or their thyroid issues, or it's the old age, or they feel that this is just part of the 50s and the 60s, and you will see that is certainly not true. The implants themselves, now there are some patients that have lived with implants for 20 years and they have had this quote nice equilibrium where the body in itself accepted them as a nice equilibrium between the body and the implant. So this one lady, she had implants from the 80s. She came to me during 1992 during the Dow Corning recall and the ban. The patients were told that you could have the implants removed. This is part of the massive lawsuit. Now, this one patient of mine, she came from the Pacific Coast. She opted in 92 to say, I do not want my implant. I'm very happy and I will live happily ever after, and I do not want them removed because I'm very happy and content. She comes to me a year ago when I saw her as a patient, and I asked her, why are you coming to me 33 years later? Because you should, and she said, now I have noticed pain. It is tender and I am not able to function, and I know something is wrong because this is not me. And lo and behold, she had what was a ruptured implant. And this is where what I say, the BII will eventually catch up to everyone, some as short of a year. So I have a lady that I did 3 months ago. She had her implants inserted in 2019. Now these are patients that I myself have managed. These are not stories of stories. So these are my patients. 2019, and all of a sudden she had a replacement of what were saline implants, and that in itself caused a stirring up of the phenomenon of the toxins, and all of a sudden her health went downhill and haywire, and she's like, I am so sick, I cannot get out of bed. And lo and behold, the implants were removed that were just a year old, and she bounced right back. I have patients on my Facebook that I have put forth 2017 gummy bears, ruptured implant on the left. And again, if you go scroll through, these are my patients, gummy bear, where you see people driving trucks over them and not rupturing. Look, these are implants that themselves were ruptured. So the implants, the breast implant illness will catch up to everyone, and it's just a matter of time. And we know this from the manufacturers who've put forth 1.8 to 2.4%, and eventually after some time, the illnesses catch on. And if you look at the vast majority of the patients, it's usually the 7 or 10 year mark. And the patients will say, well, I remember it started very subtle, 3, 4, 5 years into the augmentation, and I felt something was not right. I've heard so many times repeatedly where the patient said, the moment I got the implants, I woke up the next day and I knew that this was a bad move. And God bless that patient for being honest. And sometimes, you know, you're able to mask or say, you know what, it looks good, I will tolerate the badness that comes with it, or I may not accept, because one may not want to give up for social reasons. So now the other thing that I want to mention is, then I'll jump to the questions. Going back to, someone just said this week, oh, I was told saline implants are safe, they're easy to remove, and they're not as involved as silicone. Now, in my mind, as a board-certified plastic surgeon, who's my best patient? My best patient is the one who listens to my instructions. The best patient is the one who has saline implants, a young lady above the muscle, and she has no comorbidities and no medical issues. Why? Above the muscle, the dissection is easy. The breast tissue and the muscle in between, which is where the implant is, there's no dissection on top of the rib. The saline implant, if it's ruptured, it will be deflated like a balloon. So that's my easiest implant, and that's where I walk into the OR and I say, God's being nice to me. This is going to be a, relatively speaking, an easy operation. My toughest cases are the ones where the patient is radiated. The patient has a history of scar formation. The patient has an 800cc implant. The patient has on prednisone. the patient has below the muscle placement, and the patient is known to scar because she's not going to scar like she does on her incisional scar, for example, but also scar on the inside. So as you will see from the world of general surgery, there are people who have an appendectomy, for example, or a colon resection. 5 years down the road, out of the blue, from nowhere, the patient has a small bowel obstruction. And lo and behold, the number one cause for small bowel obstruction in an already operated patient is previous adhesions from previous surgery, out of the blue, many years later, sometimes even 15 years later. So my hardest patient is the one who is not compliant, for example, who now majority of the ladies are very good, they're understanding, they follow, and I give them text instructions. Lo and behold, I saw a patient 6 days out. She had a bra that she had to wear. This is my patient. I talked to her. And lo and behold, she has a bra that I tell all the patients where they get a zip up and down. She was wearing the bra with lifting her shoulders up and putting the garment on. And you can imagine, and she didn't wear the binder for 2 weeks from the first post-op visit. Now, it baffles my mind. Why did that happen? Where's the communication error? But I text the information to my patients. So there is no it's foolproof. There is no potential way the communication is not effective. And whenever I do give the instructions are very precise down to the T, and the patients all have my phone number for any emergencies 24/7, so that I'm directly in touch with them for whatever it may be, whenever it may be, so that I can handle whatever it may be. Sometimes the patient gets a yeast infection. Another patient complained of irritation on the eye. Now, I want to know about it because I can always call in an eye drop. Sometimes it might be a piece of hair. Sometimes it might be an eye irritation that might occur from a detox phenomenon. So I want to know about emergencies, so that is there linked to me via my phone anytime that needs to be done. Now, another thing I want to mention is what ladies now are coming back to me and saying the Khan procedure, and I'm like, what is that procedure? Tell me about my procedure. And this is where they say I'm the only one, and I'm very happy, and I don't want to be anything but, I want to say with humbleness and with thanking God, the fact that I, as a board certified plastic surgeon, I have only put in one set of implants, and I have no compulsion. I can put in 6 implants tomorrow in a heartbeat, and this is my right, but I choose deliberately, purposefully not to, because I don't want to hurt anyone. And I myself, from what I know, I'm the only one who has not purposefully done, except for that one in order to get board certified, because I saw this very early on and I said, I'm not going to hurt anyone. And this is what I believe in my mind, heart, and soul. That's the right and the best thing to do for the patient, not at the expense of the cosmesis, and it's not something that is worth it. And this is where, number one, the Khan procedure, number one, where if you come to me, 99.9% chance, if you have saline implants, you're not going to get drains. If you have a ruptured implant, my goal, task, and challenge is to put in no drains, because I'm going to be able to salvage everything in the en bloc fashion or 100% total capsulectomy. And once there is spillage of what is that honey type of silicone, be it slime if you want to compare it to, or a ruptured silicone within the chest, one is mandated, obligated to putting in drains so that all that inflammation has a passage out. The goal is to, number one, go super slow, 1 millimeter at a time, no rush. The last thing on my mind is the next patient who's hungry and NPO, because I want to do the level best, and this is the only one patient that I have. Sometimes when I'm operating at the hospital, they come and knock on the door just to kind of keep a tab on time, and they say, how long are you going to be? And I say, I'll be done by midnight. I never tell them what time I'm going to be done, or I'm never pressured or forced. They can always find another room for another doc, whatever it may be, but the length of time it takes is whatever the safest length of time, and this is my commitment to the patient. This is what the patient has signed up for, and I want each and every single patient, whenever you talk to your plastic surgeon, very nicely and assertively, but very appropriately and humbly and very succinctly, the bond you have with your plastic surgeon is what you have on that consent form, that 100-0 rule. 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind. Many people ask me, do you remove the capsule 100% of the time? I said, you bet. I won't come out of the operating room till I've done it. And it's physically removing it just like I'm seeing. And you have the surgical tools, you have the headlight, you have the right instruments, you have the right patience and the training and the expertise, and most importantly, the commitment. And essentially the whole gist of the operative experience and this Facebook Live is the fact that in my mind, when I go to the operating room, I know for a fact that the patient is only going to bounce back, get healthy, is going to have a good successful rebound and be void and free of the breast implant illness is when her entirety of the implant and capsule is removed with 0% of the capsule remaining behind. That's it. Because if I'm not going to do that, I'm not going to walk out of the OR, and I'm going to take whatever it takes. You know, yesterday when I walked out of the OR, Jennifer walked up to me and was like, oh, you were sweating. And I said, you bet I was. Because it was a tough case, and it's not a walk in the park. It is a tough surgery. Absolutely. It is not for everyone. And many surgeons will refuse outright, oh, I couldn't do it. It was too hard. The capsule was tissue paper thin. Another lady, she had her explant done in Chicago on the 6th of January of this year. And guess what? 10 days later, she was calling me. The surgeon couldn't remove. Nowadays, you pay someone, you get on a list, and you get promoted by the group to be what would be an expert explant surgeon. And what I would say, unfortunately, is far from the truth. You have patients basically being fooled into believing their surgeons are what are the that have the expertise into removing the capsule and the implant as the way it needs to be. And I say that is absolutely not true. You have to do your homework, and you have to basically ask the right questions. Your best bet for any surgeon, including my practice, is to ask my previous patients so you feel comfortable that your surgeon is going to look you in the eye and you're going to spend significant time with the surgeon, not their liaison, not their medical assistant, not their nurse practitioner, not their nurse, not their resident, not their fellow, not their anyone, but the surgeon himself, who gives you that word on that consent form that I am going to remove 100% of the capsule, and I have a track record of removing the capsule, and I won't come out till that is done. Simple as that. And anything else, the patient basically was gullible or fooled into accepting. Don't be nice. And I use the word, you have to confirm, because again, if you go to 100 surgeons, I assure you with confidence, you're not going to get this. And this is where you need to do your homework. Now, going back to the Khan procedure, I essentially 99.9% of the time with my saline patients, and well over 97%, 95%, depending on the case, I do not put in drains unless there is free floating silicone. So last year I put in drains only in 3 patients. And they came in with what was ruptured silicone. As soon as I made the incision, there was free floating silicone, and the commitment was already made. And the exam was consistent as such. And as you will see, patient after patient, where the end block has been done successfully, and you have ruptured implants and all contained, and again, all done in a slow, standard fashion. The pain is less, the better anesthetics, the better system. So going back to the Khan procedure, number 1, no drains. Number 2, no lift. 80% of the time, I will tell you with confidence, I've been able to get away without lift, patient after patient. How many patients, young and old? The 69-year-old patient I did with that ruptured implant, that 41-year-old implant, she didn't even need a lift. That patient was complaining to me, how come I never got drains? And I said, you did not need drains because it was done in the end block fashion. So no drains. Khan procedure, number 1, no drains. Number 2, no lift. Number 3, 100% of the time you're going to get caps. The capsules are going to be sent to pathology, rule out BIALCL, rule out malignancy, rule out lymphoma, rule out everything possible. Remember, this is what is the cause of the havoc, and this is what we need to look into. 4th, 100% of the times, no matter what, rain or shine, the implants are returned to the patient. This is the patient's right. This is what was in the patient, and psychologically the patient is also mentally reassured that the implant is out. And there have been so many cases, as you have heard on the previous mention, that the lot number did not match the implant. One patient was told by her reputable plastic surgeon, that a reputable University Medical Center here in the state of Michigan, that she was going to have saline implants, and lo and behold, she gets silicone implants taken out of her body. One patient I did at the hospital, she had saline on one side and silicone on the other. Now beat that. One implant was done above the muscle, and then the assistant was likely doing simultaneously the procedure, and that was put below the muscle. And there was once a patient I did, nice patient, and she mentioned this on my Facebook, where she was told she had an implant on the right and also on the left, and lo and behold, I go in and there is no implant on the right side, and there was an old capsule that I removed. And look at the times where she was told all this time she had an implant, and I told her, listen, I want two things. Number one, I want the operative record from the previous surgeon, and I read through line by line, and lo and behold, it stated very clearly that during the surgery, they made a determination, given the volume of tissue that she had from the old capsule from 1978, that they were not going to put in an implant on the right. And the patient for all this time thought she had what were implants on the right side, and she did not. And there was absolute confirmation looking at the operative record. The next is, I always take cultures from the right side and also from the left side of the chest, showing that there are no aerobic, anaerobic, or fungal problems. How many patients have said, oh, I have a fungal problem at home, a mold issue, or I know I have mold, like say at the pedicularis or at the areas that have been isolated. We want to make sure, and remember, the pathologist, when they're looking at the capsules, they will be able to see hyphae, for example. Those are the branch-like structures we all know from grade 6, grade 7, where you have looked under the microscope, that's the mold. If the pathologist is not seeing it and there is nothing of growth in the 4 to 6 weeks of incubation in the microbiology lab, that's also confirmation there is no mold. So basically the other thing that I want to mention is, which is part of the Khan procedure, is the twilight anesthesia, which is deep sedation, conscious sedation. The patient is essentially breathing on their own. So in a overall nutshell, there's two types of anesthesia. If I were to break it down, the first one is the general anesthesia. The general anesthesia is where the patient is paralyzed. Our patient is not able to breathe on their own. The muscles paralyzed, i.e. on the lower extremity, where now the blood pools, now risk for a clot. And then once the patient's paralyzed, the breathing tube is put down, and now the machine, the ventilator, the same COVID ventilator that's breathing for these COVID patients, the same machine is essentially breathing for the patient. It's very safe. It's practiced safely. But why do overkill when you have what I practice and I preach to all the plastic surgeons, is what is twilight anesthesia, where the patient is comfortable, has no recollection to date what happened in the surgery. Not a single patient to date has come forth. I have had patients where their daughter, for example, was an anesthesiologist at a major medical center, and she said, well, twilight is safe, if the surgeon is safe. And there are patients, for example, the risk for clot is minimal. The patient is basically on propofol, fentanyl, Versed, and maybe ketamine, depending on the history. And the patient is given a nerve block on 100% of my patients, and it's very safe, very effective, and there is no problems with issues. Now, there are times, for example, when I was operating on a patient 68 years of age at the hospital, as soon as I made cut, the next thing you know, I see an abscess. Now, I want the patient to be comfortable. I said every single patient gets SCD boots, which is to help with the sequential boots on the lower extremity. And then I gave heparin sub-Q so the patient doesn't get a clot. And then I continued on once the patient was intubated, because I wanted the patient to be comfortable, because it was below the muscle, and I want the patient to be paralyzed. And I went the next level up, because that I felt very strongly was safe and better for the patient, especially when I was going to be dissecting below the muscle and I was going to do a washout. And whenever you have an abscess, you have to put drains in, and I felt that was the right thing to do for the patient, and I'm very happy, and the patient overall did very well. So now I just saw a question, where are you operating? So I have a full AASF, which is the quad ASF, which is the highest level of surgical facilities outside of the hospital, where, as you will see across the country, there is a gold standard of operating room where the surgery center operate, and this is what I have, and this is where I operate. I do not like to go to the hospital for many reasons. When I do go at the hospital, I find that the anesthesiologist is different. I do not know who's my circulator. I do not know who's my physician assistant or my assistant who is my surgical tech, because the rooms changed. Someone may have a week off, and there's so many players at the hospital. And if you find, the infectious rate, COVID exposure amongst many others, and those who are in the medical field will certainly affirm the fact that like the gold standard surgery center, the Quad SF, is the better, safer, healthier place where I handpick my own team, and there are no surprises. They know exactly what I want, and they know my routine, and they have it down. Does insurance pick up any of this, or is it all out of pocket? So I will tell you the biggest, and I say this very boldly, the insurance is the biggest evil of all. I want any person who is an insurance analyst, financial analyst, who has worked with insurances, anyone who works for the insurance companies, they will attest to you, in today's world and age, insurance is a big scam, a high deductibles, everything is passed to the patient, and they don't want to pay the doc, they don't want to pay anyone, and they all say bundle. And the hospital, along with the insurance companies, are in on together to what is a profit-making enterprise, at the expense of the doctor, at the expense of the patient. And overall, on paper, it's all about looking good. In reality, it is not about the patient. And I'm not exaggerating. You can ask other doctors. When I first came out of my fellowship, I thought the world was like Mother Teresa. Nice, high five, everything is good. What you see is what you get. And I'll tell you, everything is 90% of it is bad, 10% of it is good, and you have to seek out the goodness. And I will say this to you, any surgeon who says that this is going to be covered by insurance, the reimbursement rate is anywhere from $500, $700, $1,200, pushing it max $1,500. That will not justify 4 or 5 hours of surgery. That's a reason for Chapter 11 bankruptcy. And to the point where I've stopped dealing with insurance companies. They are by far getting away with so much, and it's amazing to see, even with this past election, they got away with everything. And look at the reimbursement for a colonoscopy, for example, or an appendectomy. They even will say, look, textured implants that are banned. You would think the insurance companies would cover the tab for removal. They say, well, no one told you to remove them. There is no mandate from the FDA or any of the societies. Even though textured implants are banned, you would think they would say, get them out tomorrow. Look, we live in a motor city. There's a problem with the airbag. All of a sudden, they're sending, letters after letter. They're making a recall. I had a Samsung Note 7 phone. There was, I think, 35 reports of the phone blowing up, if you remember, from like 4 or 5 years ago. There used to be announcements on Delta and all this. There was a massive recall of millions of phones just because of 35 phones blew up, and there was a direct association. Look, textured implants that have been banned are directly associated with lymphoma. There is no scare. The only thing the FDA did was, Allergan, this is what they did. Allergan, did you reach out to the 52,000 patients who had textured implants? And that was the only thing. And if you have textured implants, there is no recall. There is sleep happily, you're going to be okay, but we're going to ban it because it's associated with lymphoma, but don't be scared. And I will tell you, this is not a recall. This is basically, basically putting a Band-Aid on what is a real problem. You would think the insurance would cover these? No. Now, they say we're going to cover grade 4, but majority of the times when it comes to writing the check from the insurance companies, they say, well, cosmetic in, cosmetic out. Some of them have said, who told you to remove the capsule? That's overkill. That's not the standard of care. That's unjustifiable. And no one wants to accept the fact, no one wants to pay. I had a patient even with breast cancer, the insurance company declined and said we're not going to pay it, which is absolutely illegal. The point here is, any plastic surgeon, quote me, any plastic surgeon who is going to spend 4 or 5 hours and who's going to get reimbursed $500, $700, $1,200 for what would be 5-hour surgery is undeniably going to be in what is a recipe for bankruptcy. This is just like saying, nowadays the insurance companies do not support this. They do not want to accept this. And everyone seems to be looking the other way. I'm not being hard. No, I want you to look into and do research. I saw a financial analyst today. She works for the insurance companies. There are many of the patients who work for the insurance companies. They'll speak, and the ladies that work and men who work for the hospital, you know what I'm talking about. Come forth and you can share your stories. There is no shame in that. This is what I live and I see every single day of my life. And it's amazing to see how business of an aspect medicine is, more so plastic surgery. And unfortunately, this is the world we live in. Having said this, again, do your homework, do your due diligence, ask the right questions, be assertive. That's your right. Just like you have a bill of rights, the patient has a bill of rights, and this is your entitlement on. When you have a consent form, you have to ask your surgeon directly, and this is who you should have met once, twice, so that you're absolutely certain. Now, what I want to do is I'm going to go ahead and go back to the saline implants. Remember, they're as bad as silicone implants. Remember, the same ladies who have saline implants, they're the same ones who are experiencing the same BII symptoms as the ladies with the silicone implants: suicidal ideation, the whole series of BII symptoms, from brain fog to fatigue, GI issues, vision problems, high blood pressure, breathing issues, chest pain, amongst the many others. So again, I find that's critical. Now, one thing I also want to mention, there is one of my patients, Trina Simolen. She has started a Facebook support group, and it's called Bra and Binder and Everything for Explant. I support something, it can get relatively expensive. This is a nice Facebook site where, just from what is the postage is what needs to be done. And this is a nice lady with a good heart who's trying to help whoever can help, basically in whatever manner, because it ultimately all adds up. Now, the other thing I want to discuss here is, can you explain what is an en bloc total capsulectomy and a capsulotomy? Now, if you go to my YouTube site, you're going to see I actually get on a board and I describe this, and I'm going to describe. En bloc basically means where you have an implant and the capsule, and the entirety of the implant and capsule was removed as one system. So there was not even a millimeter break into the capsule. So anything, whatever it was, contained. That's the gold standard. That's what we're all striving for. This is what all the commitment needs to be, and this is what you need to ask your surgeon. Now, the next level down is 100% total capsulectomy. Sometimes, truly, even in my hands, the capsule is so thin that inevitably during the retraction or during the dissection, there is a millimeter or two. Now, the most important thing is the entirety of the capsule is removed. Now, in situations where this is a non-ruptured silicone or a saline implant, it truly doesn't matter, but you want to always do it because you never know what's on the inside. And this is where the surgeon tactfully, very carefully, through a lap sponge, or is able to suture that during the dissection, but 100% of the capsule is removed, such that 0% of the capsule, and this is still, relatively speaking, acceptable. And one cannot trust a surgeon who says, I do en blocs 100% of the time. That's virtually impossible. Now, what is unacceptable is what's to follow next. I did a partial capsulectomy, which means I removed 90% of the capsule and 10% of the capsule was left behind. And you hear surgeon after surgeon say, oh, I did it for your benefit. It was just too hard. It was so tightly adherent to the rib. And I say that's an absolute no. The entirety of the implant and the capsule needs to be removed as one system, with 0% of the capsule remaining behind, because that 5-10%, when that remains behind, that will continue to haunt, trigger, and hurt the immune system. Look, those of us who got the COVID vaccine, it was a small amount that was injected. That in itself was enough to instill those antibodies, and that will continue to help protect us. Same thing, if you leave some of that behind, the body will continue to fight. Maybe 30%, 60% of the symptoms might be alleviated, but not 100%. And this is where the significance of 100% total capsulectomy comes into play. And a capsulotomy is where the scoring of the capsule is done, where a capsular contracture occurs and the surgeon essentially expands the volume so that a larger implant is replaced in the place of the first. And that's an absolute no. So please go to my YouTube channel, Khanplasticsurgery Academy, and you'll see me on the whiteboard kind of describing and drawing. And please share it, and I'll go ahead and try to push it up such that you can see it. Next question, I have had small tuberous breasts, had internal scoring. So tuberous breast deformity is a congenital / anomaly where there is an inner ring that needs to be scored such that the breast tissue falls out through the parenchyma. Now, I keep hearing, and this is what the patient is stating, quote, keep hearing about scraping adhered capsules off of the chest wall ribs. Now, I'll tell you, there's no such thing as scraping. Imagine when you do the barbecue and you have the food on the grill. When you remove or burn off, you're going to find that sometimes there are small chunks of metal the meat on the metal that's left behind. That is, and if you were to look at the analogy, that's part of the capsule. That in itself will be enough to hurt the patient. So the goal here is very tactfully, very sophisticated manner, as you will see, and hence this is the picture of the chest wall showing that the entirety of the capsule is removed, not burned off. You will hear patients say, or the doctor say, well, I did the best I could. That's not an answer. I did the best I could. We're not talking to a child who's trying to clean up as best as I could. No, this is a pretty serious matter. Just like you would remove cancer, you have to remove it in its entirety. You don't want to leave it behind. Sometimes the surgeon may be scared to dissect off of the rib because you might lead into a pneumothorax, which is air within the lung, which is a surgical emergency, which means that a chest tube needs to be inserted. That is a major surgical emergency, and I will tell you, a surgeon who does not feel comfortable putting in a chest tube will never dissect off of the rib in a manner that needs to be done because they're going to feel, quote, not confident in their dissection. And so I find it's critical that your surgeon should and must know how to put in a chest tube and be able to manage a complication. Now, I'll tell you, as a board-certified trauma surgeon, general surgeon, and a board-certified plastic surgeon, it takes a lot. You have to be really not knowing what you're doing in order to cause a pneumothorax. How many pneumothoraces have I had? 0. And hopefully never, because the dissection is done in a very nice plane. There are some times where I'm dissecting on the midline of the chest. That's where it is the hardest part. As you go further out, the rib cage is round like a cylinder, if you will. That becomes easier. So you dissect all the way around till the hardest part is in the midline or the center part. And then guess what? Believe it or not, I have dissected off of the cartilage of the rib. And as you will see, that's part of the anatomy, especially of the younger patients, where you dissect off the cartilage so that you're removing part. Now that is, I don't want to use the word traumatic, but the patients overall do very well because, again, the goal and the fixation and the commitment and the determination and the whole overall enthusiasm here is for what? To removing the entirety of the capsule, because you don't want to leave that behind. And I say this to you, and I said this to my office manager, 20 years from now, I cannot think anyone else would do the surgery any differently, which is that the entirety of the implant and capsule must be removed in what is the 100-100-0 rule. 100% of the time, 100% of the capsule must be removed, and 0% because this is what the patient wants and needs in order to bounce back healthy. So the dissection, whether you have tuberous deformity, now when you score it, the breast tissue will fix itself. So regardless if it being adherent or not, the entirety of the capsule must be removed. Next question. I was diagnosed with lupus approximately 3 years after getting implants. Autoimmune doesn't run in the family. Guess what? There are millions of people who have autoimmune issues and their family never had thyroid issues. They never had lupus. They never had rheumatoid arthritis. It certainly can be spontaneous, just like breast cancer. So you cannot associate and say, well, I got lupus because I got implants. So millions of people, men included, much less men, but more women, who have autoimmune issues, and they may certainly have lupus. Now, their symptoms may be worsened by the BII, but I never tell any patient that your Hashimoto's or your lupus will be improved when you remove the implants. I say you need to have your due diligence. You need to be optimized for your lupus, and time will tell. God only knows how you're going to bounce back post-operatively, such that your lupus hopefully will go into remission. Maybe it might stay the same, maybe it might get worse. Time will tell. And I'm not a rheumatologist. I don't understand lupus, except for the fact that it is a pretty serious disease. kidney problems along with vasculitis amongst many other associated symptoms that needs to be managed with medical optimization by a board-certified rheumatologist who continues to titrate the medications. So just today I got a patient with rheumatoid arthritis, young lady, 35, came with her husband today. She was officially diagnosed with rheumatoid arthritis. Now, she did her reading, she did her homework, and she said, well, they put me on methotrexate and all these other strong immunomodulators, and they wanted to suppress my immune system. She herself, on her own, made a decision, I'm not going to go on those meds because those meds were hurting her. And sometimes the patient is taken off these meds because their toxicity of these medications. She said, I'm going to get the implants out and I will see how I bounce back before I commit to these medications. And I said, that's between you and your rheumatologist. My commitment to you is one, to get the implant and capsule out. And when we look back, we don't say that 3% or 5% was the capsule was left behind. No, 100% of the capsule was removed so that your body is in equilibrium and your body will have a chance to bounce back to its normal state of health, hopefully minus had you not had the implants. So she stopped seeing doctors and started seeing functional medicine doctor. Now guess what? There's another patient I saw just today. One of her, and she's likely watching because she told me she was going to watch, her doctor actually fired her as a patient. She said, you need to go see a psychiatrist. I cannot reason with you. You are not maintaining well. You're fixated on this BII business, which is a myth. And I officially discharge you from my clinic. Go find yourself another primary care doctor. Because they said it's in your head. They kept attributing it to potential other causes except for breast implants. That was not even in the equation. So currently, of all meds for autoimmune, ask the plastic surgeon if implants cause this, and the answer was no. Now, I'll tell you, I never tell someone that, like I said earlier, the autoimmune issues are going to resolve or you're going to get better. I always ask the patient, I cannot and I will never make or tell the patient you're going to get better. I will tell the patient 100% the implants are only hurting your body. 100%. There's no questions asked. And I want anyone to deny the fact. 100% of my patients who have explanted have felt this. Number one, they had wished they had never inserted implants. And number two, 100% of the time they felt that they had wished they had removed the implants and they had never inserted them. The point I'm trying to make here is the implants are only replete with problems after problems. So the bottom line is, once the implant and the capsule is removed, time will tell how you're going to bounce back, and majority of the patients bounce back. Now, if you go look anecdotally from my patients, now I've not done an evaluation, but almost 80, 85, 90% of the patients bounce back and they do well. And this is echoed and reflected. And again, the only two other colleagues who I have faith in, Dr. Chan out of the Los Angeles area and Dr. Feng out of Cleveland. And again, they echo the same numbers. The lady that came from Chicago, she has a biopsy on her right lymph node that shows there is multinucleated giant cells, and this is consistent with silica. She already has a ruptured implant with silica that's dissipated to the sides and the rest of the body. Even when you remove the implant, she did not bounce back, and she knew that the implant, a slow seeding of the silicone had made it to the rest of the body, and removing the implants was not going to give her the bounce back to good health. So you will see the many ladies, and again, this is a generalization and research needs to be done, who do not bounce back are the ladies who have had implants for 30 years. They have had a rupture, silicone noted, and we know the silicone has made it to the lung. Look at Dr. Atul Mehta's biopsy that he did and analyzed with electron microscopy and with energy dispersive x-rays that clearly proved with definitive 100% certainty that silica had made it to the lungs. And this was seen on the CT scan with the ground glass opacities that we know. If you go back and look at that Facebook Live with Dr. Atul Mehta, who's the pulmonologist out of the Cleveland Clinic. And we know from the biopsies that have been done of the different organ systems of the body that showed on biopsy after biopsy that the different organ systems in which were the silica. So the bottom line here is the vast majority of the patients do very well, and more research needs to be done. There needs to be more analysis. Now, what I'm planning on doing is I'm trying to reach a biomedical lab and a biophysicist lab here in the area, where I want to take the contents of the saline implant that has been in a body for a period of time, to study that, to spin, to see what is within the saline, because this is where the rupture happens. And if you were to have a patient with saline implants go to 100 board certified plastic surgeons, what happens? They rupture the implant and they remove the implant, 20 minutes one side, 20 minutes the other side, and you're out in an hour. What I want to show is there's silicone inside that saline. You centrifuge it, you do an electron microscopy, and you do the energy dispersive x-rays, and hopefully a blood test that can be done that will assess the blood after it's centrifuged to see if there is free floating silicone. Because remember, this is what Dr. Atul Mehta taught me, that the only way that the silicone made it from the lungs on this lady with saline intact implants is through the blood and directly deposited into what is the lung parenchyma, and hence seen on the biopsy. So what exactly is capsular contracture? Are they avoidable? So capsular contracture I talked about earlier is a capsule that forms around the implant. It takes on average 4 weeks to 8 weeks for the body to form essentially what is a scar around the implant, just like you would form a scar. Now, this is, in the grand scheme of things, we do not know why this happens, but there are associations with what is bacterial biofilms, infections that form around that cause hardening. So on some patients, believe it or not, you have a patient who has a capsular contracture on one side, grade 4, and on the left side you have normal, grade 2, for example, or grade 1, on the same patient, and you would think they both would be having a capsular contracture. And this may be just because it was delivered. Now, there are other tools that, like the Keller funnel, a small hole through which there is a touchless technique, changing of the gloves. Some people love to wash it with the antibiotic irrigation or some betadine, and there are associated problems with each, or the touchless technique using the Keller funnel. But the vast majority of the capsular contracture, and it occurs in a fair number of people, and if one is predisposed to capsular contracture once, they will very well get it again. So they certainly are avoidable. If you put the implant above, you have, relatively speaking, higher chance versus where the implant is placed below the muscle. And any reputable board certified plastic surgeon, if you were to go to 1,000 board certified plastic surgeons, 970 of them will put the implants below the muscle, because that's the better, more predictable, and proven to be better, safer, and long-term results, and that's why this has been practiced. Now, next question: can a pregnant woman with implants has major BI symptoms pass any symptoms to the unborn child? Now, this is something that I'll say I do not know, but now and I do not know the answer for this. What's interesting is, I did this. A lady has hepatitis C. All right, very common in the Middle East and some parts of the world. Patients who have liver issues. You would think the mom who's breastfeeding would be able to pass HIV or Hep C. Now, interestingly, I looked this up just out of my curiosity, and it just happened to be one day thinking about it. The answer is no. Now, I do not know the answer. More research needs to be done. And I know anecdotally, look, BII is real. We know this because there's 350,000 complaints with the FDA, all the problems that the implants cause. But I have not heard children of these 20, 30 million women who have had implants where there is a direct association with autism or other issues or other problems, and more research needs to be done. There's nothing that I read into. And if there's anyone, we need better studying and more information, and I would not lose sleep over it. People who breastfeed or nurse and have implants, there's been no associations of problems, and there are millions of people who have done that to millions of other kids, newborn babies, and there's been no associations, at least to my knowledge. Next question, what would be some reasons you do not perform an explant on a patient? Good question. So this is my patient, my practice. I want I use the word stellar results, and I want perfection. And I am OCD, and it's my practice. As you will see, on Monday, I believe I saw 11 patients. All day today, I saw 13 patients. I myself, I have some assistants, but I'm the one who's doing the reading before, after, during, talking to the patients. You will talk to me for as short as 20 minutes or as much as an hour and a half. You may come see me twice, thrice. I filtered the patient. So to answer the question, there was a patient that I booked 2 weeks ago. We clean the floor with bleach, with soap. Make sure, just like you would at the hospital, from one room to the other, absolutely 100%. After every patient, there's bleach in every room, at the doorknob, at the chair, at everything. The thermometer is, the temperature is taken, and with perfection. This lady had a reactive airway disease. Very nice lady, very smooth lady, and I'll tell you very much with it. And super nice. I canceled her case. I did not want her to get a reactive airway disease, asthma induced from what is bleach. Another patient, believe it or not, she came all the way from Corpus Christi, got on the plane, flew here. Hi, how are you? I examined her. I hear wheezing. Case canceled. She's crying. I spent so much money. I said, you know what? Let me call your doc. I got my phone myself. Called her doc. With all due respect to this sister, my friend, my patient, and I said, doc, tell me what's going on. Why is she wheezing? And she turns out that she needed to be on Singulair because she didn't want to be on prednisone and gain weight. She chose electively on her own not to get on that medication. Case canceled on the spot. Now I told her I'm not going to go play golf. I don't play golf. I'm not going to do anything. My staff is waiting. We're waiting for you. We've prepared for you. You're not optimized. Case canceled. Another lady, super nice in the medical field. She could give a lecture on BII from Virginia. God bless her soul. Ejection fraction of 40%, in that range. I felt uncomfortable operating on her in my surgery center, and I needed to do her at the hospital. And I would offer her the same surgery that I would offer the 26-year-old healthy on no medications. Now, because of the insurance issues and at the hospital, the entire bill was coming out to an obscene amount, which, again, the insurance company's trying to capitalize. Again, she was out of network or, not in her group. And I said, the surgery on her own. Now, I said to her, I don't want to do the surgery in my surgery center because you don't meet criteria. You have to, if you have a pacemaker, you have a high BMI, you have problems. I don't want any issues. I don't like turbulence. I want like a nice smooth sailing. I don't like surprises at all. Another patient, guess what? She's scheduled for next week. Her blood pressure was elevated, surgery canceled. Another patient got pregnant, surgery canceled. Another patient refused a COVID-19 test, surgery canceled in a heartbeat. I don't want a patient, look, one of my friends operated on a patient, plastic surgery procedure. She got a tummy tuck from my colleague. They didn't do a COVID test. I don't need to do a COVID test. Majority of the surgeries done don't need or require a COVID test. I require a mandate because I want perfection. I don't want any issues. I don't want any surprises. This patient of my friend who had the tummy tuck, 2 days after had shortness of breath. Remember, when you have a tummy tuck, you're tight. You cannot take a deep breath. She was young. And the next thing you know, she became susceptible to COVID. And lo and behold, ended up in the ICU. I do not know if she got intubated or not, but she certainly got admitted. She had COVID, what would be an opportunistic infection, and she would be able to fight it off had she not had an abdominoplasty. Guess what? She became susceptible to this COVID, and she unfortunately had a problem. And this is where I say, when you get the surgery done, you are quarantining yourself and making sure, remember, this is chest surgery. And I want you to take a nice deep breath. You have a bra and binder, and we want good recovery, and we don't want to take any chances whatsoever. Another patient came from Arizona, a nice lady. She didn't have a sitter. She came by herself. She's like, my husband's too busy. I got 3 kids. I'm on myself. I said, surgery's going to be canceled till we find someone who's going to sit for you for the first 24 hours. And lo and behold, we have a nurse who we basically let you hire for the first 24 hours. So she's physically with you, shoulder to shoulder, making sure you're not going to get up in the middle of the night, fall and break your hip, things like that, which has happened before. But I could have said, well, you sign here and you're on your own. No, I want 100% no surprises. I want things to be maintained and controlled in the most sophisticated manner with no chance for any badness. I'm responsible from the beginning to the end for anything that happens. And I take pride in my work. There is no compulsion on my end. This is my practice, and I want to make sure that the patients that come to me, that they get 110% out of me, and it's all about quality control. It's all about the perfect delivery, and I want the patients, each and every one of them, and hopefully, each one of you feels like that. Now, I want to go ahead and mention one other thing. There are obviously disappointments because nothing is perfect in life, and by all means, I am not what would be a miracle worker. Thank God, and I say this very openly, this is fair game, and I wish every single plastic surgeon, anyone who says they have had no complications, two things. Number one, either they're not telling the truth, or number two, they're not operating. Like my friend who's retired, he's not operating. Obviously, he's not going to have complications. So thank God to date, I've had 0 infections, and I'm very particular and deliberate about how the patient is prepped, from the time the patient gets on the OR table to the patient leaves, and even after, about exposure to water. Many people have said, oh, I love that 4-minute shower. I don't want someone to be exposed to water, and the next thing you know, the water gets in and around the incision and sits, and the next thing you know, it's nice and warm at the inferior aspect of the breast. Sometimes if you have good amount of breast tissue, it's a perfect environment for the bacteria to grow. And sometimes you have colonization in some patients of fungus, bacteria in that area. You have what is the inflammation, panicolitis, inflamed rashy tissue. Thank God to date, I have had to date only 3 hematomas. 1, 2, 3. Each one, I'm going to go by one. The first one occurred within 24 hours. I take full responsibility. It was a technical issue on my end because that is my issue. What did I do? There was bleeding around the muscle. Could I have prevented it? It happens. And what happens within the first 24, 48, 72 hours is my bleeding issue, where a hematoma is a collection of blood that forms and pools, and it's under pressure, and it's like a black and white. Something is wrong. My right side is 3 times the size of the left, and I am in pain, just like you would find. And it is a surgical issue. If you have drains, that drain will not allow blood because it automatically clots. You have to physically go to the operating room, and again, a clean environment. This is where you have the cell phone, and you physically evacuate the hematoma, find the bleeder, cauterize, and likely put a drain, and that's how you manage. And that's exactly what I did to that patient. She called me. I said, run to the OR, run to, and I saw her. I took care of her. This happens after any surgery. Someone has a thyroidectomy, hematoma. They will always talk to you. Surgical emergency. My chairman of surgery, the king of endocrine, he had a hematoma, and I was the intern on the floor, and I'll tell you, it is a surgical emergency. This is true after someone gets basically a fall and, like say, a knee replacement, and the next thing you know, one of the vessel gives, or someone has a thoracic surgery, or open heart surgery, or someone who has a meningioma of the brain. You could have bleeding inside, right? So this is true for any surgery. What are the risks for any surgery? Bleeding, infection, hematoma, scar formation, acute or chronic scar, chronic pain syndrome that can happen, right? Now, going back to the second patient who had the hematoma, was a nice lady, post-op day number 9. Nurse. Remember, I've already seen her in my clinic. Excellent. No pain, no issues, nice symmetry, doing great. All of a sudden, day 9, out of the blue, from nowhere, she has that, and this is from excessive movement. And she said it herself, and she said, I knew I was overly exerting because she felt good. She was doing great. She was off the pain meds. She was all of everything, a nurse. And I'll tell you, this is nothing that I would have done. And I told the patient, were you on any of the blood thinners? No, she was not. And my third patient, post-op day number 11, she slept well Thursday night. I talked to the husband. wonderful, the nicest, sweetest patient you're going to find on earth. Friday morning, she gets up. All of a sudden, she is complaining of that hematoma. And this was an overly exertion in bed or something like that. God knows what it was. But nonetheless, needs to go straight. And any surgeon can evacuate it. You don't have to necessarily come to me. And the most simple thing is making a small cut, and the basically blood is let go and the pressure is released. And it can happen on any surgeon's watch. And anyone who says they have not had a hematoma after a colon resection, after a gallbladder surgery, after any surgery, you will find that is a surgeon who is not openly honest with. And I'm very upfront, and I'm very happy to share. Otherwise, other than these 3 cases, thank God to date, and I told my patients, each one, I can, except for the first one, I cannot imagine I'm going to change my practice or my rule or anything. And that's why I say to the ladies, T-Rex arms. You can move your arms, you can move your elbows, you can brush your teeth, comb your hair, you can type 6 hours straight, no problem. Because you remember, you got a nice compression, and I ensured that everything's done. And again, of the many surgeries that I have done, and I say with confidence, this is patient. Now, I want you to see the patients that I'm doing. So on the 26th, I'm doing a lady who's on Eliquis, which is a blood thinner, and she is going to get explantation done at the hospital. She had a settle embolus, which is a PE, a pulmonary embolus, which can be lethal, a history of, likely from the oral contraceptive pills. Now I have to do her at the hospital, and I could choose and say, you know what, I don't have to sweat it. No, I'm going to offer her, I'm ready for the challenge. I did another case during the COVID lockdown, a young lady, 37 years of age. If you go back and look at the Facebook Live, 37 years of age, has a 5-year-old kid who has severe pulmonary hypertension, life expectancy 3 years. I did her case at the hospital, high-risk patient. I did an 81-year-old lady who was driving her car, spun on ice, chest ended up hitting the steering wheel, implants from 1982. Managed by the trauma team, free-floating silicone on the right chest with on Coumadin for her AFib, blood and silicone in a right chest. On Coumadin, INR of 2.5, I operated on her, evacuated the whole thing, put drains in, and offered her the same surgery that I would anyone else. Another lady, history of clots on Plavix. Another lady on blood thinner, offered her the surgery. And luckily on those patients, you would think they would be getting a hematoma. No. But the bottom line here is those 2 patients, and again, I don't want to blame anyone. I don't want to say anything, but I ask myself, and I ask each one of your listeners, what would it be that would have prevented it? And I asked the other surgeons, and I would say it's the physical exertion that caused a tear in the muscle and hence a bleed. And that's basically what led to what would be a hematoma. Because remember, they had 9 days to declare, and the other lady had 11 days to declare, with all due respect. And maybe if I was the patient, I would move around a whole lot more, because if I felt good. So hopefully that answers the question. So I like the fact you don't do drains. Now I say to everyone, listen, I have no mercy on anyone. If I want to put a drain in, I'm not going to say, oh, I'm going to be nice to her. She came to me all the way from California. She told me she doesn't like drains. I could care less. If a patient needs drains, I'm going to put them in because the patient needs it, period, the end. I'm not going to think if she's here from out of state or in town or whatever. If a patient needs a drain, the patient needs a drain. And remember, a drain will not evacuate a hematoma. I'll say this again. A drain will not evacuate a hematoma. And a drain is there to collect any fluid if the surgery is not done right. And I find 99.9% of my saline patients and at least 99% of my silicone patients do not need a drain because of the way I dissect. And this is one of those procedures. And confidence. And I have a whole track record of patients where I've done it successfully. And I tell all my other plastic surgery colleagues, absolutely, the surgery needs to be done delicately, very succinctly, very nicely, off of the rib, off of the muscle, such that it's a perfect dissection. And I'm going to have a whole series of videos now that I have almost 30,000 pictures. I have so many videos. I'm going to be uploading them on YouTube so that, you know, I got banned from Facebook for 1 month. That was a hard month for me not to be able to talk to my patients. But the bottom line is you have enough of the videos already to see how I dissect and how I manage the patients. So I'll be flying in from Hawaii. And I'll tell you, I just took care of a patient 3 weeks ago from Maui. Another patient who's now recovering in Maui, swimming every day. I have a patient that came to me from Panama, from Japan. I had a patient that came to me from Germany. And again, I have a patient that's on her way from the Dominican. So many people from all walks of life, all different nationalities. And this is where, you know, what I do is, again, I am very open. You know, one of my friends, as you have probably heard me say, so how long after the surgery is the risk for hematoma? I will say from my experience, on my surgical end, the first 24-48 hours. The risk for hematoma, you could exercise, pull your arm muscle up 3 weeks later and potentially hurt or stretch the muscle, correct, which has just been operated on and may precipitate one. So from my experience, the first 3 weeks, 2 to 3 weeks are important as far as compliance. And this is where I make sure. Now look, this one patient that I mentioned, she was supposed to wear the Haga Prima bra and there's a zip. God knows why she put her arms through and put them on 6 days into her explant, and she did not wear a binder. Look, she got a small pain and she's been wearing the binder every day by inserting both her arms up, as you can imagine, trying to get the Haga Prima bra on without using the zipper. She did not get a hematoma, nothing to do, you know. And so look, there's another patient who did like a physical exertion 6 weeks out, the 72-year-old patient. She had some pain that resolved. This was more like the sprain. So the bottom line here is, I would say from my comfort level, 2 to 3 weeks go by and there is nothing that would eventually precipitate, from my experience, what would be a hematoma. Remember, hematoma is a vast majority of the hematomas. You talk to the ladies, especially in the breast augmentation group, you ask 1,000 ladies who have had hematomas, when did you get it? All of them will say in the first 24 hours, or in the PACU, in the recovery, as soon as I went home, then the same night. That's the first 6 to 12 hours. The first 24 hours is when it happens. And I want the ladies to state, who have had complications with hematomas, that this is how soon it happens. Not only that, but it's the thyroids, for example, or, you know, thyroid is a big deal because, you know, you have the airways affected, and this is true under even in the best of the hands. So compression isn't going to create the force. Compression isn't going to create the same force gravity suction will. Now, gravity suction is a very, under a bulb syringe, is you know, sometimes a foreign body than in itself. And again, if the dissection is done right, the need for the drains is not there. Now, this is normally, so how long do I have to wait for my surgery? So this is what I tell my out-of-town patients. So I took care of a nice lady that they're doing a documentary on. A team of a producer, a director, and a cameraman flew from California February 18th of last year. So the entire crew flew in from Los Angeles, and they filmed me in the operating room to see how I do what I do and why I do the way I do it, and why am I different compared to all that. And this is a movie that will be, a documentary that will be coming out shortly. So this one patient, just to use her as an example, and she's going to be part of that. This was a patient that they brought with them. Very nice lady. I talked to her on my own, electively called her, and I said, tomorrow is the 1-year anniversary. And she's like, oh, I'm glad you remembered. I said, I think of you every time I remove an 800cc implant or a large implant. Because she's a lady in her mid-50s, 800cc implant, breast cancer patient, large 800cc implant on the left, 800 on the left, on prednisone 5 milligrams. Now that's a largest implant, and prednisone, which is going to be a potential risk for wound healing. In her, she's coming from Los Angeles. I said, you're not going to, no drains. I told her, you're not going to go back till I give you the green light. So she normally would have stayed the 6 days. So if I do my surgery on a Tuesday, I tell my out-of-town patients, come to me. I do the phone consults, and I tell them, come see me on Monday. Monday, I get to examine you. I get to see you. I write the scripts. You get to see me. This is part of informed consent. You feel content. Your sixth sense is good. What you signed up for. You're seeing me. I'm seeing you. Tuesday, we do the surgery. And then on the day of the surgery, I know exactly how the day went. How easy it was. Was it a home run? Was it, involved surgery? Did I have to sweat it out over 7 hours, which I've done before? Then I make a determination. I'm going to see you. So Tuesday, I did a surgery. I saw the patient today. I said, I want you to come back. Nice lady from Wisconsin. Just to be complete. Sixth sense, I wanted to make sure she was going to do well. She had a bra change at the last minute. So going back to, then I see my patients either that Friday, which is post-op day number 3, or I see them post-op day number 6, which is the Monday. A week shy of their, a day shy of their surgical post-op day number 6 to be exact. So I then at that time, remember you have 6 days. You've remember the patients are talking to me. God forbid they have nausea or they don't feel well. I'm like, okay, come to me in my clinic. I'm going to see you. They're usually staying at the Staybridge, which is right across, and so there's a direct link between them and I with my phone, so I know what's going on. I don't feel well. Come to me tomorrow. I want to see you. Or the 41-year-old lady who had, the 69-year-old lady who had 41-year-old implants. I said, come to me tomorrow. You're 69. I want to make sure you're doing well, and I want to make sure when you're 69, the recovery is different compared to the 26-year-old, for example. So I want to make sure they're doing well, and any emergencies, i.e. irritation of the eye, I want to know about it because I can call in eye drops or, like I was mentioning, a yeast infection. I can call in the diflucan. But on average, 6 days into the surgery, I see them. And at that time, I feel very content. I remove the tape and I tell the patients, go home. Sometimes post-op day number 4, I tell the patients, go home. I don't want to see you because you and I can talk and I feel comfortable and confident. It was a nice home run in the surgery, which majority of the patients are, and all of them do very well. Now, sometimes it has happened where 3 weeks out, there's a small, for example, a seroma. That can, on its own, go away. It happens even after a tummy tuck or a facelift or any of these other surgeries, or it, it can be managed passively and without any intervention. Could you upload your Facebook lives? Absolutely. I'm going to go ahead and do Instagram. Now I want to mention, so another person asked me today, she was my last patient, Brazil, a nice lady. She lives here, but she's from Brazil. Very nice lady. She understands plastic surgery very well. There's a lot of plastic surgery in Brazil. So she basically asked, how come you don't advertise? And I said, I have not spent a single penny. The only one thing that I did was over the summer, right after the COVID break, I just put a commercial out for breast implant illness, just so that, I'd be the first person to talk about it, the Cosmopolitan magazine, the Fortune magazine. But I have spent $0 on my webpage, $0 on my advertising, $0 on Google advertising, $0 on anything. And I continue to spend. Now I have uploaded some videos just so I can educate the patients. As you will see, I polished my YouTube videos, but zero marketing. I have not paid any, unfortunately, and I say this very boldly and unfortunately, very seriously, I have not paid any Facebook group or any Instagram group, and I have received a lot of invitations from a lot of people asking for, quote, donations to market, and I am very happy to state I have not fallen victim to their greed, and I am very happy to state that I do not have anyone influence my decision. I don't have any Facebook group owner, Instagram owner, TikTok, whatever it may be, And unfortunately, there's so much of this going around where someone donates a little bit of money here and they get promoted on their Facebook, and the person who is the manager of what is the large group has no idea other than what is a financial commitment with no comprehension of what the surgery is. And unfortunately, you have to be careful as patients to see and kind of maneuver yourself and guide yourself so that you don't fall victim and prey to these unfortunate plastic surgeons who truly do not comprehend what is breast implant illness, who claim to be sympathizers, but in reality, absolutely are not. Next question. If I sign a waiver, so I take a picture on 100% of my patients of the implant and capsules on the table. I take a picture of the chest wall. I try to take as many videos. Remember, I have to have someone, a nurse, being available. But, again, the proof, and very much proof, is in the videos and in the pictures, because they speak volumes. They speak for themselves. The many Facebook Lives, you would have no clue what was done except for what the pictures show. And again, all those 5 criteria. Now, what I would love to know your advice on the best way to inform the other medical professionals about the toll this has taken on our lives. The Facebook Live that I did previously was another nice lady, a friend of Tracy Gary, who's been instrumental in the world of BII, letting the FDA, other professionals. There was a symposium, a few months ago where they had like a whole series of doctors come in and talk about what is breast implant illness. At the end of the day, you have these 4 groups of people. You have the plastic surgeons. No one's going to talk. They all say it's a myth, unfortunately. The manufacturers are laughing themselves the way to the bank. They say it's the standard of care. It's safe and effective. You look at all their advertisements. Unfortunately, that's not true. The next is the FDA. Unfortunately, the FDA is sleeping. Just like they're slowly acting. They put the black box warning out, the black label box warning in regards to the detrimental effects of the implants. They banned the textured implants only after France were the first country to do so. The last but not least are, the doctor community is like totally like, if you go talk to dermatologists, look, my patient told me today she got fired by her doc who said she was crazy and she needed to go see a psychiatrist and that she was fixated on something that's a myth. The patients are the ones who are driving this. And unfortunately, what you need to do is you need to write to your senators, to your local representatives, to your local journals, medical news people. Look, the Grand Rapids News, one of the patients, her significant other worked for the news company, and he was instrumental and resourceful enough to getting them in and interview me and talk about their before and after. So there was like a before and after analysis of how they improved dramatically with their explant. We need to write gently, nicely, humbly, and the before and after pictures speak for themselves. And we need to have more of these Facebook Lives, which I've now decided to do as a general public so they can watch, so that ultimately the world knows and understands what is so real. The same reason why they were banned, we're reliving this phenomenon again. And so that everyone understands what is a real problem that not only hurts the patient, but also hurts the significant others, the children, the friends, the family. It taxes the economy, and I would say something that's absolutely not worth investing their bodies into. So one thing that I want to mention, so please comment on the inverted nipples after surgery. So I just want to mention, there are so many different patients with so many different reactions to the implants. One patient had, so very important question. I'm going to go ahead and end with this. I'm just surprised it's 8:43 right now. One patient had, scar tissue and indentation of the nipple. This is after my surgery, I as the surgeon. And this is what I would call, if you want to call it a complication, but this is what I would say a known effect of what is explant surgery. Now, I'm going to push some scenarios. A lady with a BMI of 18, 19, 20, large implants above the muscle. Look at all when I use the word large implant, 650 cc's, 525 cc's. Now you can see the thin tissue is so thin because you can actually feel the implant that is right underneath the skin. So the risk of nipple skin necrosis is certainly there. If you remove the implant, you can only imagine what's going to happen to the skin. It's going to contract inwards. Now, if you do like a mastopexy or there's a risk for nipple necrosis. There's a lot of inflammation. Another lady that came to me, she had a lumpectomy that was managed with radiation. She went to a plastic surgeon. Plastic surgeon put in implants above the muscle. And guess what? She had what was fat grafting at the same time. Now you can only imagine that the amount of tissue deficit she had that led to the implant and the patient who had radiation done. She's a setup for nipple necrosis, infection amongst all the other badness. And she comes to me and she says, look, my right side looks different compared to the left. And I said, guess what? 4 things. Number 1, implant was above the muscle. Number 2, you had a radiated chest. That in itself is a reason not to put in an implant, period. Don't take a chance. Number 3, you had fat necrosis, i.e. whenever you do fat grafting on the face, 30% in the best of the hands, the 30% of the fat dies. If you do inject in the breast tissue, 50% of the fat dies. Now this poor lady, she has history of breast cancer, status post lumpectomy, radiation, and implant above, where she had a lumpectomy. Now you remove the implant. Remember, she had a lumpectomy affect the deficit, and she has an irregularity of the chest. You bet she has to. This is just like saying 10 minus 5 is 5. You're going to have a deficit. Another lady, nice, pleasant lady, the nicest of the patients you're going to find on earth. Healthy lady, but she has got Crohn's disease. She's on an immunomodulator that alters wound healing. Many surgeons would not even want to basically remove the capsule in her. If you look at her surgical scar from another previous abdominal surgery, you will see the scar is very involved, very irregular, very thick, and very haphazard. This is how she heals. Now, on the one side, she healed very well. I was very happy and content. On the left side, she had what was an indentation because of the significant loss of volume. She doesn't have much of a BMI, where her fatty tissue, normal obese tissue, we all have, I have, that would hide and mask what would be the deficit. And she had more inflammation and some contracture. And remember, she's predisposed to forming scars. Luckily, and I say this very happily, she didn't form a nipple necrosis. She didn't form a wound dehiscence. And this is very similar to someone goes and gets an ear piercing, and the next thing you know, the patient gets a keloid or a hypertrophic scar of the ear. We have all seen it. Young, innocent, healthy patient, teenage, all of a sudden now you're going to get a scar over here because your body is telling you. Now, sometimes people come to me for a scar revision. You know what's the first question I ask? Tell me the other surgeries you've had. And she's like, well, I had a gallbladder surgery. I had a scar where I had trauma on my leg when I was ice skating accident. And I said, let me see the scar. And you can see it's a horrible scar because we know people of some ethnic descent, for example, the African Americans, some Middle Eastern people, some people of East European descent, some people of Caucasian descent, but a predisposition to forming hypertrophic or keloid scars. No matter what you do, they're going to form because that's how they heal. This is just like saying, why did I get a capsular contracture after my surgery? Doc, could you have prevented it? And guess what? The best way to prevent a capsular contracture is not put the implant, because then you don't have a chance. Same thing. If you have a implant and that needs to be removed, especially on a lady who's BMI of 17, 18, 19, 20, or even 25, and she's prone to scarring, she's going to scar whether you like it or not. And there are certain inherent risks associated with explantation. It is not void or free of scarring, just like any surgery. You got a lady, she got a thyroid scar, and you can see from a distance it's well lit up. One lady went, my own patient, she went to a salon and she got a chemical to do, she had hair, polycystic ovarian syndrome. She put a chemical she bought off Amazon, and the next thing you know, she formed big keloids. I'm going to post her picture. She's given permission to post. big keloid scars on her chin. She went to 4 different plastic surgeons before me. And she came to me with complaints. She had big scarring. I said, you know what am I going to do? Cut it out? I cannot put it together. It's going to be under stretch. I offered her what was artificial skin, which is Integra, which is the shark cartilage, and bovine collagen, which is the standard of care burn surgery approved FDA in 1996. And I offered that to her chin because there was no other skin. I was not going to take skin from her thigh or her back because it would leave another hypertrophic scar or keloid on her back. And the point I'm trying to make here is then I had her be radiated so that she would not have scarring that would reoccur. And I would tell you, this is like, imagine cauliflower on her chin all the way. That's the patient, the risky patient. She came to me and she sought me out through reviews and word of mouth that I was the person who I am on the artificial skin lecture board, and I've done enough of this and given lectures literally across the country and presented all over at the Burn Association meeting if you go look at my CV. The point I'm trying to make here is certainly that was a risk that I took. Now I had her radiated. Radiation minimizes 3 consecutive days chances of recurrence of what is a keloid on her entire chin area. And the point I'm trying to make here is that's a risk, and I deal with scars. So for me going in, I had to find a smart way, a unique way, a different way so that she would not scar. Now, there's no such thing as a scar-free surgery. If you have a 560 cc implant above the muscle and you have all that tissue that's thinned out, now you could certainly cut the skin out, but guess what? That's a tissue that's already diseased. And from my experience, anyone who tries to do a mastopexy that day will ultimately lead to nipple and skin necrosis, and that is what I prevented. Now it indents inward. Look, the right side healed fine, right? Left side, the pathology was different, more inflammation, God knows what. But the point I'm trying to make here is surgery comes at a risk, but the goal of the surgery is, remember, I want you to, each and every one to remember, when I do the surgery, in the vast majority of the patients, the implant is below the muscle. What do I do to the nipple? What do I do to the breast tissue? What do I do to the muscle? Nothing. Zero. Zilch. If I touch any of those, I'm only going to distort. So the next time when the patient gets a mammogram, it's going to highlight with fat necrosis, scarring, and that's why I tell all my other colleagues, don't make an incision around the nipple areola or down, because what happens, you cut through the breast tissue, the breast parenchyma, you get fat necrosis, nipple, i.e. you have scarring of the nipple areola, you have ducts that are altered, and then you have breast parenchyma that is basically cut into, that may cause calcifications, irregularities, dehiscence, widening, and an unsightly scar where the approach is at the bottom. And that day, the whole commitment is to removing the entirety of the implant and capsule from an incision that you're going to hide in the crease, such that no intervention is done to the breast tissue or to the nipple areola or to the muscle, and that portion above the muscle is remain untouched, and the entire surgery is done below. My surgery below is a 4-hour commitment, and what baffles my mind, how the surgery below the 4 hours that I normally do, plus what I don't touch anything, that inevitably leads to a loss of volume and falling down of the skin or scarring down, because that's where the inflammation was, because the patient has no breast tissue. And as you can see, just like one of my patients explained, a bounce house collapses, the skin collapsed because of the gravity effect. Or maybe like one of my patients, the previous surgeon inserted the saline implant through the nipple and made a small hole, rolled the saline implant and went in, and lo and behold, that's only going to scar down, because now you have a less of volume, and this is on. Now, is that preventable? My job is to go below the muscle. I don't want to touch the nipple areola amongst that tissue, because at that time, and vast majority of the patients do not need a lift, and they do very well. And I have to date probably 4, 5, 6 patients that have been relatively, quote, lack of a better word, unhappy with their scar. Now, I wouldn't recommend in that patient, for example, on with Crohn's disease with a strong immunomodulator to go in and get, because she can be a risk for nipple necrosis, skin necrosis, infection, because she's set up for that, right? Because she's already had inflammation, implant, and scarring, and amongst other things. If she, now let me ask you a question. If that lady with Crohn's disease were to go to her the general surgeon who removed or did the colon or the small bowel resection, or can you revise my scar? No one would ever want to intervene surgically, because you're setting up for potential more adhesions, more scarring, more problem. Same thing, someone who's got a keloid of the ear. Oh, can you do a touch-up and fix? No, you basically, the treatment here is you cut out the keloid of the ear, you send the patient for radiation for 3 consecutive days, and don't touch the ear. No more piercings, no more, because you're only going to repeat the same. So I say this to you, you know, and again, for someone as a plastic surgeon who I love to operate, you know, I am a big fan of DNT, which means do not touch, don't do unnecessary surgery. And then you will see these patients, one side looks very nice, optimal, excellent, and I use the word excellent, aesthetically pleasing. The left side or the right side is the one that's scarred in, or you have these indentations, and that is the challenge of the explant surgery. Now, let me go ahead and quickly answer like 2 quick rapid fire questions. Does he require an MRI beforehand? I do not want an MRI in a saline patient. It's not ruptured. If I have a patient who has implants from, like, say 1991, these are almost 30 years old, very likely they're ruptured. I want to know what's the status of the lymph nodes, what's the status of the implant. Very likely it's ruptured, because remember, with length of passage of time, if the right one is not ruptured or the left one has free floating silicone, I'm going to start off with the right side. If it's ruptured on the top medial aspect, I'm going to dissect all the way around, because I know this is a trouble point. And my surgery day, my job is to go in, get as much information beforehand so there's no surprises on the OR table. What basically that means is it's like a Navy SEAL mission. You come down from the helicopter, you want to grab a bag, take whatever you need, and out. Same thing, I want to go in 30-year implants that are creating havoc, BII, for a patient. It's an elective imaging, the best imaging study without contrast. So going into a 25-year or 30-year-old set of silicone implants, and going into the surgery knowing that the left side has free floating silicone, let's do the right side first, and the left side is free floating on the posterior inferior aspect on the lateral, then I know the dissection is going to be more on the other side, so that I know I'm kind of looking out for that. And we know the MRI has been proven wrong. How soon after the surgery can you shower? I say day 6. The reason behind that is in 24 to 48 hours, the skin becomes watertight. I give another twice the time period so that the capsule, I give it twice the time period, 4 to 6 days, for that to be super watertight, so that when I remove the tape, there is no discharge in vast majority of the patients. And then I have the patients take the 4-minute shower, so that when the water washes through, it doesn't involve what are those self-dissolving sutures, the monocryls, and they essentially have a chance over the next 2 to 3 months to dissolve on their own. So that's my formula, if you will, and call it my way of doing it. But thank God to date I've had no issues, no problems with wound dehiscence or issues like that where I've had an infection. Now, what is the significance of the bra and the binder after the surgery? The tightness as well. And with this, I'm going to end. You look at all the YouTube videos. When I get done, I have that retractor pulling up. You can put a large implant, 300, 400, 500. Look, all that void, that empty space. What happens when you do a tummy tuck? What happens when you do a gynecomastia patient? You want to have to wear a 6-week bra and binder religiously, correct? You do a thigh lift. What do? You have to wear a garment that goes from below the knees all the way up into the waistline, so that you have that compression. Because we don't want, as you walk, twist, and turn in bed, to basically potentially hurt the tissue. There's swelling, right? So this is the reason behind where you have not only the compression against the chest wall, but kind of a small recoil that helps lift the recoil. What are the Cooper's ligaments? And especially in the young ladies and the many ladies even in their 50s and 60s, to help hold the breast tissue against the chest and lets it heal so that there is no need, just like a gynecomastia patient. Go back and look, and if you can type in on my private breast implant illness and even my public, the gynecomastia patient, grade 3, everyone had told the patient that you need to get skin removed, and look, the skin retracted back on its own, and the vast majority, and this is the need for the compression. It helps with the pain. If you fall off the bike, you apply an A-strap pressure, guess what? You feel good. That in itself helps with the swelling, the comfort, and allows for wound healing to occur in an optimal way, especially with the skin recoil. And overall, just like in any patient where there's a significant loss of volume, allows for the skin to adhere nicely over to the chest wall. Prevents seroma, prevents other problems, prevents other issues that could potentially go wrong, and allows for a nice aesthetic result. Now, just today, that Brazilian lady that came to me, the last patient, super nice, she said, guess what? At 3 weeks out, she's 28 days out. Excuse me, she was done on the 28th of January, and today is the 18th. She's 3 weeks out from her surgery. I told her no binder and no bra, giving her exam. Now, this is me, her BMI, her physique, her results, and this is the purpose behind me talking to my patients. And this is where many of the patients ask, oh, I've been waiting for a consult. You know, I have so many patients. When I get done, I have to call Texas, Washington, Hawaii. I have to call all these. That's my obligation. And that, believe it or not, consumes me, because I want to make sure they're healing well. That patient from Colorado, for example, or the patient from Missouri, so that they're heading in the right direction. And then I gauge by talking to the patients the feedback. All right, I want you to stop the binder at night and only the bra at night. So I want you have the gravity effect, you're healing, and I want good results during the day when you're up and active, about and driving or going to the grocery store. I want you to wear the binder at that time. But when you're sitting down, my nice patient from Chicago, she's also 3 weeks out. Today I told her don't sleep with the binder. No need for the binder at night. Now this is unique. The other lady who has a lot more breast tissue, I didn't tell her. I told her additional 2 more weeks. And this is where I, from my experience, having talked to so many ladies, some ladies starting to get an indentation. I say, stop. I want you to go ahead and let it fluff out. And lo and behold, look, if you remove your sock right now, you're going to see these indentations, the pattern on your skin. Same thing. You remove the binder and the bra, and it allows for the fluffing out phenomenon, taking into consideration the swelling has come down and now the skin is going to normalize. So it is a nice balance and pattern, which is I have learned over the last several years as to how and best manage my patients. Now, I'm going to say, do your homework. This one patient looked up and did her research on BII for 3 weeks. I tried to encompass and touch base and summarize all the other Facebooks into what would be a 2-hour Facebook Live that I did. I want to go ahead and mention, my job is to help, and this is what I'm going to do. I'm going to come out with a series of videos, series of the Khan procedure, the Khan criteria video, many videos, which the patients have been awesomely nice in regards to sharing. No one knows who they are. No one will ever know their names, but that way the ladies can talk about their experience before and post before and after pictures, so that the world can read your story, read and understand what you have been going through is unacceptable and certainly is not the standard of care and certainly detrimental to your health. These are the breast implant illness that have been recalled. They're the many reasons the implants cause the harm and the hurt, not only mentally, physically, and I will say in every regard, spiritually, and in everything you touch, every moment of your life, be it the small things or the big. and this is something what I tell the rest of the world is not fair. And I'm very fortunate that in my short career, something that I believed in from the bottom of my heart, that what is the number one common procedure done by plastic surgeons, which is augmentation, I chose electively not to do, because, you know, do no harm. That's the faith, that's the oath, that's the hope that I have in all my doctors, you know. And I say this from the goodness of my heart, and I mean no ill will, you know. I would love to do 6 augmentations tomorrow and have work half as much. But this is something that we owe to the patients, we owe to humanity, and we owe to the rest of the world as leaders in healthcare, and so that we make this world a better place. Anyways, take care, everyone. Thank you very much. Please share the video so that we can spread the good word and we can enjoy life, because this is not a rehearsal. Take care. Bye-bye.